I'm Amy. I'm the service coordinator for Guthrie Orthopedics, and welcome to Joint Class. We'll start off today with what most of you don't have, and that is a healthy knee. If you look at the x-rays, you can see that the femur, which is the top bone, meets the tibia, which is the bottom bone, with a blank space in the x-ray. That blank space is actually your cartilage and your synovial fluid that allows you to walk, jump, and move without pain. So for many of you, this is more what your knee looks like. This is a bad knee. The femur and the tibia are actually rubbing against each other, causing you pain and discomfort whenever you walk or move. This pain has caused you to change the way you live your life, whether that's just stopping from going to check the mail, going out to do a walk in the woods, or whatever it may be. You've decided enough is enough, and you've found a surgeon who can fix this problem. How we fix this is with a total knee replacement. Total knee replacement is not the proper terminology. It's more of a resurfacing. We're going to resurface the femur and the tibia and cover them with a metal implant. We're also going to use a polyethylene liner in between, which is now going to take place of your cartilage. We do this to improve your stability in your knee, take away your pain, and get you back to doing what you've stopped doing because of it. So this is a model of a knee replacement, and as you can see, we have the femoral component, the tibial base plate, and the polyethylene liner. The femoral component and the tibial base plate are cemented into place with an antibiotic bone cement. The polyethylene liner actually snaps into the femoral component and are now going to be your new joint and hold everything together for you. Some of you may only be receiving a partial knee replacement. A makoplasty, or a partial knee replacement, can be done on one or two of the compartments. You may need a total knee replacement, which we wouldn't know about until we've started the surgery, if there was any issue with one of the crucial ligaments in your knee. The ACL, which runs right down the middle of your knee, has to be intact and without damage in order to hold the knee together. If you have any issues with these ligaments, you would not be able to have a partial knee replacement. We would need to do a total knee replacement. For many of you, a healthy hip is what you're looking for. This is an x-ray of a healthy hip. You can see that the femoral head and neck go into the acetabulum, making your hip joint. In this x-ray, you can see the space between the femoral head and the acetabulum. That again is the cartilage, the synovial fluid that allows that joint to move freely without pain. For some of you, this is what your hip actually looks like. The femoral head and the acetabular are rubbing against each other because that cartilage is gone. The white in the x-ray is actually the damage of your hip from that grinding. The body is also trying to band-aid that damage with what we call bone spurs. Bone spurs end up trying to push the bone away and relieve your pain. However, it doesn't work. The bone spurs end up actually causing you more pain in the long run. Again, this pain is causing you to not do the things that you love to do. It's impairing your lifestyle, and you've had enough. At this point, you're trying to find out what you can do about it. A total hip replacement is better terminology than a total knee replacement because we do take a large chunk of the femoral head out. And we replace it with a metal implant and again a polyethylene liner between the two. So this is a model of a hip replacement. We're going to burr through the femur to make room for our femoral stem. The femoral stem is gritty in texture, which allows the bone of the femur to kind of grow and hold on to that implant. We're also going to clean out the acetabulum and make a nice smooth space and make room for our acetabular shell. The acetabular shell is the same type of material as the femoral stem, which allows the bone to grow and help to hold it into place. We're going to put in a polyethylene liner into the acetabular shell to allow space for the femoral head to snap securely into place. Unlike the knee, which is held together with cement, the hip is what we call press fit. So the gritty texture of the femoral stem and the gritty texture on the backside of the acetabular shell allow the bone to kind of grow into it and hold it together. And then with the weight of your body and the muscles and tendons in your hip, it holds everything into place. Prior to surgery, you're going to go through pre-admission testing. Basically, pre-admission testing is a long extended doctor's appointment. It can last anywhere from 3 to 4 hours. At that appointment, you're going to be seen by a doctor of internal medicine. They're going to make sure you're healthy enough for this elective surgery. They're going to do blood work, they're going to do EKGs, and possibly a chest x-ray. You're also going to meet with a physician assistant or nurse practitioner from orthopedics. They're going to discuss the actual surgery that you're having. Lastly, you're going to meet with a doctor of anesthesia. The doctor of anesthesia is going to discuss your options for anesthesia during the surgery. One of our options for anesthesia is a spinal anesthesia. Spinal anesthesia is our preferred choice. However, it's not the only choice. With a spinal anesthesia, we're actually going to inject a numbing medication into your back, which is going to numb you from the waist down. You won't be able to move your feet or feel your feet. Once we get you positioned for surgery and we know that you're comfortable, we're going to put you in what we call a dreamlike state. Basically, if you've ever had a colonoscopy or an upper GI, it's the same type of medications. You won't know, feel, or see anything that is happening with your surgery, unless you want to. We can do a spinal anesthesia with no sedation, and you can be awake during your surgery talking to your doctor. The risks with spinal anesthesia are limited. However, there are a few. Mostly is after surgery you may have trouble urinating because we've put everything to sleep. The benefits to a spinal anesthesia are the fact that when you wake up, you do not have that nausea, vomiting feeling that you might if you get general anesthesia. You also still can have pain control from that spinal for up to 24 hours after your surgery is complete. It does lower your risk for pneumonia afterwards because you don't have the breathing tube in place. General anesthesia is the other type of anesthesia that we use with these surgeries. General anesthesia, we put you completely asleep, we paralyze your body, and we put in a breathing tube. We do all the work for you. One of the downfalls to general anesthesia, again, is that nausea feeling that you may have when you wake up. And we are also unable to know if while we're doing the surgery, we've given you enough pain medication until you wake up. As soon as you wake up from surgery, we are right there with pain medication if needed. Lastly, at pre-admission testing, if we haven't already done this, we're going to be checking for staph or MRSA. MRSA is a staph bacteria that is resistant to particular antibiotics. Staph bacteria is normal. It's on our body every day. However, it does like to hide. We're going to test and treat if you have what we call a colonized amount of staph bacteria. And where we're going to look for that is inside your nose. If you are positive for MRSA, you're going to have different antibiotics for your surgery. You're also going to be treated with a nasal antibiotic. You use this nasal antibiotic for 5 days leading up to the day of your surgery. If the morning of surgery and you've used that antibiotic, you come in and we retest you and you still remain positive for MRSA, you will be kept on what we call isolation precautions when you're on the floor. Basically what that means is physical therapy and occupational therapy will come to you instead of you going to group physical therapy. If you are positive for staph, which is a bacteria that is treated with any antibiotic, there's no isolation precautions needed. However, we will still treat you with a nasal antibiotic before surgery. We also talk about anticoagulation after surgery. One of the methods that we use for anticoagulation is a sub-Q injection, which means it goes into the fat of your belly, called Lovenox. We use Lovenox for 14 days after your surgery to help reduce the risk of blood clots. The reason why I bring this up is because Lovenox may not be covered under your prescription drug plan. We ask that you call your prescription insurance company ahead of time to make sure that it's covered. We also want you to get this prescription filled prior to coming into the hospital for your surgery. Sometimes pharmacies do not have enough of these injections on hand, so they have to fill it, and it may take a few days. If your insurance company does not cover this injection, the clinic pharmacy here in Sayre offers it for a very competitive price. This is my soapbox, dental work. We do not want you to have any type of dental procedure 6 weeks before your surgery and for 3 months after your surgery. By all means, if something comes up, especially after your surgery, you have an infected tooth, tooth pain, something like that, we want you to get it taken care of. However, you will be placed on a lifetime prophylactic antibiotic before every dental work that you have, including cleanings. Preparing before your surgery. Throw away the throw rugs. They become a tripping hazard. When you go home, you're going to be walking with a walker and you will be shuffling your feet more than you do now. A throw rug becomes a tripping hazard. We also want you to make sure that you have enough space around corners and down hallways to get around with your new walker. If you are taller than 5'6", you may want to consider a raised toilet seat. You're going to be learning how to sit and stand differently than you are right now, and it's easier to not have to go quite so far with that raised toilet seat. If possible, move your bed to the first level. You will be able to do stairs before you leave the hospital. However, you're not going to want to go up 14 or 15 steps every time you need to go to bed or to the bathroom. You want to check your handrails, make sure they're nice and tight. If you don't have any, you may want to consider installing them. The last thing you want to do is grab a hold of your handrail when you first go up the stairs and have it come out of the wall. If you're considering rehab, we suggest that you look into 3 facilities before you come in. The reason why we do this is because your first choice may not have availability on the day that you're ready to discharge from the hospital. We would prefer you to have a second choice rather than have us come in and say, Rehab A doesn't have space. Where else would you like to go? And lastly, you're going to want to stock up on essentials and easy to prepare foods. The last thing you want to have to do is go to Walmart when you come home from surgery because you ran out of toilet paper. And do your exercises. The exercises prior to surgery are just as important, if not more so, as doing the exercises after surgery. When you're packing for your stay here at the hospital, you're going to want to bring sneakers or shoes with a back and a non-skid sole, comfortable clothing. We're going to be looking at that incision multiple times throughout the day, so you're going to want to have easy access for that. Whatever you want to sleep in, you're going to get dressed every day so you do not have to wear a hospital robe. Whatever you need for the restroom, like your toothbrush, toothpaste, anything like that. Yes, we do have toothpaste here, but it's nasty. I bring my own. Your Medicare and insurance cards, and some form of identification. I have yet to figure out why somebody would try to steal somebody else's total hip or total knee surgery. However, they will ask you to prove who you are when you get here. Bring your patient education book and a list of any medication changes that you've had since pre-admission testing. Do not bring your medications to the hospital with you. Our pharmacy will take care of all your medication needs while you're here. And hydrate, hydrate, hydrate. I cannot stress enough on how important it is to be hydrated before your surgery. Arriving for the hospital, you'll get a phone call the day before your surgery with your exact arrival time. If your surgery is on a Monday, we will call you the Friday before. We're going to give you your actual arrival time for surgery. We plan on your surgery taking place about 2 hours after that arrival time. You're going to arrive and go to the surgical waiting area on the 4th floor. We suggest that you leave your luggage in the car until you've made it to recovery, and then your family member can go get it for you. If you are coming alone, by all means, bring your luggage with you because we're not going to let you go get it after surgery. After surgery, you're going to go to Joint Camp located on 7 Northwest. Joint Camp is a special unit. It's what we call a closed unit, which means there are no patients allowed on the unit with an active infection. We also have a team and wellness approach. The team part comes from you, your family members, your doctors, the nurses, physical therapy, occupational therapy, and anybody else needed to be involved to get you the best result we can get from this surgery. The wellness focus comes to the point that you are a healthy individual with a bad joint. We want to send you home as a healthy individual with a good joint. While you're here, you're going to go to education classes and physical therapy. Physical therapy is twice a day, once in the morning and once in the afternoon. If you're only having a partial knee replacement, our goal is to have you here for 2 physical therapy sessions. After your second physical therapy session, if everything's going well, you get to go home. Joint Camp has private rooms, a very uncomfortable sleeper chair for your family members to sleep on. Your family can shower in your room. You can't, but they can. And we have a group therapy room for physical therapy. When you come for surgery, you may want to bring a coach with you. A coach can be anybody from a family member to a neighbor or just a close friend. If you don't have a coach that can come with you, we become your coach. Coaches have a few jobs while you're here. I like to call them your cheerleader. They're here to make sure that you know you can get through this surgery. These surgeries hurt. They cause pain that you feel differently than you did before you came in. This pain goes away. The coach is here to make sure that you know that you can get through this surgery. Coaches are very important to the recovery process and being able to get patients home quickly. Coaches, you may be the cheerleader while they're here in the hospital, but you switch hats when you get home and you become the drill sergeant. You need to make sure that they're staying on top of their home exercises, their pain control, and eating healthy. Some of the things that you'll be doing to help out: keeping on top of deep breathing and coughing, individual exercises, going to group therapy with the patient, and walking with the patient to group therapy. You get to push this big clunky chair down the hallway, so if they can't make it, you can get them there the rest of the way. And again, to help with those exercises when they get home. Some risk factors that we have with surgery: pneumonia. Although it's uncommon, it is a little bit higher of a risk if you have general anesthesia versus spinal anesthesia. So we're going to have you exercising with an incentive spirometer and taking nice, slow, deep breaths and coughing, especially after surgery. Infection is also a risk factor that we have with any type of procedure. You're going to have IV antibiotics before and after surgery. With that, please make sure you let us know of any type of allergies you have, not just to medications, but to food also. And last but not least, blood clots. Blood clots may be one of the scariest risk factors that we have for surgery. When you come in, we're going to put on what we call intermittent pneumatic compression devices. I know it sounds like a torture device, but it's really not. It's a cloth sleeve that's going to wrap around the lower half of your leg, and it pumps up and mimics the movement of your muscles if you were walking. That will be on while you're in surgery on the non-operative leg, and then when you wake up, it'll be on while you're sleeping and off while you're up and moving. You're also going to get those bright white compression stockings. You know, the ones that take 5 people to put on? You get a pair yourself. The reason why we use the compression stockings is because we're fighting swelling in your legs. The more swelling you have in the leg, the more risk you are of impeding that blood flow and developing a blood clot. We also are going to use some type of anticoagulation. Most of the time we're using Lovenox or aspirin, depending on your surgeon and your surgery. Last but not least are my friend, the ankle pump. I know it sounds silly, but it's probably one of the best things you can do to help keep movement in your legs. And it's just simply that, pumping the foot back and forth and keeping the blood flow going. You can do this while you're watching TV, the car ride home, especially if you take a long trip shortly after your surgery. You're going to want to continue the ankle pumps while you're traveling, and if you're traveling more than an hour, I suggest you stop and walk for at least 10 minutes every hour to every 2 hours of your trip. And by all means, if you have any type of pain and swelling in your calf, redness in the calf, or you have that feeling of something just doesn't seem right, please go to your local emergency room. We'd rather you do that and have it be nothing than have it be something. If you're having hip surgery, you have a few precautions to know about afterwards. These precautions are going to be in place for about 3 to 6 months after your surgery. One of them is what we call flexation. We don't want you to bend your hips towards your knees. Another is what we call rotation. So we don't want you to turn your toes inward to the point where you can dislocate your hip. And last but not least, abduction. In other words, we don't want that hip to cross the midline. So when you're sleeping at night, you're going to be sleeping with a pillow in between your legs to help keep that leg from falling midline and putting you at risk for hip dislocation. After about 3 months, the hip starts to heal up, the muscles come back into place, the tendons get tight, and it holds everything where it needs to be. Some of the most frequent questions I get are, when will I follow up after surgery? Your first follow-up will be about 2 to 3 weeks after surgery. The next question I get is, when can I drive? You can drive after that first follow-up visit and only if you're off all narcotic pain medication during the day. This means you can take pain medication at night, but you can't take it at midnight and go for a drive at 2. That's cheating. The next question I normally get is, how long is my implant going to last? Studies have shown that a hip or a knee replacement can last upwards to 20 to 30 years. Your implant is going to outlive you. Another question I get is, how long of a recovery period am I going to have? Every patient, every surgery, and every joint are very different. On average, a recovery period is anywhere from 6 to 12 weeks. I've given you a lot of information today, and I'm sure I haven't answered all your questions. Please give us a call. We'll be more than happy to answer those questions for you. Or schedule an appointment. Nobody needs to live in pain. Thank you. Have a great day.